to death. Okay, they just aren't worried about stuff. So the key word here, having or requiring an illness, but a disproportionate preoccupation with it. There's a high level of anxiety about health, and they are easily alarmed about personal health status. Here's one. You're going over a lab, and you look at the lab sheet, and it'll be like, red blood cells, it'll come back 0.01 below the normal range, so it has a little L by it. It's low. What does that mean? Is that the beginning of cancer? What does that mean? And there's like, oh gosh. So with people like that, it's like everything is really in good shape. Just don't go over details with some people, because if you do, you will be sorry. And this group of people actually will everything. Is my kidney starting to go out? What's happening? What does that number mean? It's an artifact of whatever. That will not help it. That will not satisfy the anxiety mostly. Okay, the individual performs excessive health-related behaviors, like repeatedly check his or her body for signs of illness, or exhibits maladaptive avoidance. So there's some who overdo health-related behaviors, and some who underdo because they want to avoid that fateful day when they finally confirm, yes, you have cancer. It's been cancer all. I knew it all the time. Nobody was telling me. And then you finally tell them they're afraid that it finally will be confirmed. So if they stay away and nobody says it, then it will go away. But they're worried about it all the time, no matter what. I have people now some people actually do excessive health-related behaviors. They got issues going on too. Have high blood pressure, check blood pressure every 15 minutes. They'll bring you a log back each day. They will bring you a notebook where the pages are all just crinkled up, where they have reading after reading after reading after reading. Diabetics check blood sugar over and over and over again. And they'll bring you these lists. You go, oh my gosh, you don't even need continuous glucose monitoring. You just do it all by yourself. There's no need to put the monitoring, it just goes. And it's like these are the people who have too much information. It's like, I don't need you to know that. Don't check it. Probably it's not that helpful. Good luck. But they will go on. So these people will do one or the other. They have the preoccupation with illness has been present for at least 6 months. So that's pretty much your little cut point for almost everything, is how long something goes on. And then when you code this for care-seeking type, care-avoidant type. So you have illness, anxiety, disorder, care-seeking type. They're the ones who do the excessive behaviors. Or you have illness, anxiety, disorder, care-avoidant type. The epidemiology, onset is usually in young adulthood, no preference by gender. It is a familial disorder, but there is no evidence of genetic input. It's probably behaviors learned in family groups that just kind of get passed along to family groups, so it just kind of runs the family like that. So maybe it's a learned behavior. There is usually a history of childhood abuse or of serious childhood illness, which may predispose to that disorder in adulthood. So children who get sick, like maybe they had leukemia as a child and they recovered from it, but they had months and months in a big old hospital with all kinds of things going on, and they learned all kinds of ways that people treat you when you're really, really sick like that, and they might want that again some way. Maybe that was helpful to them. Maybe that fulfilled an unmet need of some sort. It may follow a major loss, stress, or a serious but ultimately benign threat to the individual's health. Okay, they had a close scrape, or they had a bad thing, but they recovered it, and they learned a lot of how people treat you when you're sick, and that's better than the way I was when I was normal. People just ignored me, but then I was important. Now I'm not important again, so maybe I want to be loved again a different way. The patients often present with fear and concern about disease rather than symptoms. It's what they think they're going to have, what they might have. What others experience as normal aches and pains are seen as evidence of serious disease. And serious, I've had people that every little twinge, every little muscle thing, when I move my arm, it just kind of hurts. And it's that thing, it moves when it hurts when I move my arm like this. What should I do? Don't move your arm like that. I mean, it's just, it's almost stupid, but it's what you can say. They relate history in a very detailed manner, often with little affect. You will know these folks. You'll be doing history of present illness, and you will be worn out. They have every detail down. No, but I need to tell you this, and then I've got it. I understand. No, but this, and it's like, okay, got to start being suspicious for other things. They tend to be emotionally constricted and are limited in social, occupational, and sexual functioning. Many keep their own personal medical records. Many own medical references. Many people surf the internet, for Medscape and all kinds of health information. And woe is the day when the Daily Oklahoma puts some health issue on the front page because they will have it. And I always read the paper before I went to clinic because I wanted to know what was in there, because there were always a few who would kind of worry about it, or I've had that, do I have that? So you have to kind of know what's going on to save yourself. Patients will feel a short-lived relief when reassured they do not have serious disease. That's why it's important to have a good relationship, because you can at least calm them down. But within hours or days, will doubt assessment and return for another visit. Okay? So the job with your patients is to meet needs in the moment and move on. And then meet needs in the next moment and move on. It's a chronic set of relationships. To treat it, you have to rule out organic causes, obviously. Don't waste tests where there's no reason to do it. And again, like I said, the insurance will help you know not to do it. They won't do it. Patients see problems as physical, not psychological, so referral to a psychiatrist may destroy a report. Tell them it's in your mind, and then you are dirt. That is not what they want to hear. It is real, and they want you to buy that. They constantly scan their bodies for symptoms. Each new complaint should receive limited evaluation. They will have a lot of comorbid conditions, anxiety, depression, OCD, disorder, very common. And if you are going to treat them with the medication, just know they are also overly sensitive to medications. So start at low doses, encourage patients to tolerate side effects, don't escalate things, minimize, don't oversell things, just do a lot to help them not go the wrong pathway. And when you have reached the limit that you think is appropriate for that therapy for that person, given their response and what you can diagnose, then just put up a barrier, a limit. You have to create a boundary, healthy boundaries between you and healthcare or somebody else. You do not let them define for you what it is. Okay, the prognosis, chronic fluctuating course. Cure is not anticipated. These patients may be with you for 30 years, or if you just get tired of them or they get tired of you, they'll be 30 years with somebody else. And probably they float around. There may be some improvement with treatment of comorbid conditions. If you fix something that's really broken, then maybe they'll begin to believe that they're not as bad off as I thought they were all alone. Patients with transient hypochondrosis in response to acute illness or life stresses have good prognosis and possibly a complete remission, but that's a unique group. Mostly, cure is not anticipated. Okay, now this was kind of funny.
Do you ever get scared that you can't Parkinson's disease?
Not specifically Parkinson's, but I'm not going to lie, I've had my bouts with hypochondria.
What's that?
That's thinking that you have diseases that you don't really have.
Hypochondriasis, that's when you think that you have diseases. You kind of imagine and basically you think that you have something that you probably don't have. It's mostly in your mind.
So what's the problem this time?
This time I really think I have something. I mean, I'm absolutely convinced of it. It's not like that adenoid thing, where I didn't realize I had them out. So that was what I was saying.
I saw your father this week about his sinus, and he complained of chest pains.
Well, this guy's the reason I'm contracting the family. I mean,
What's wrong, Andy?
Just got a headache and seeing double, and I got songs stuck in my head and my teeth hurt. Also, I'm hungry.
Okay, well, some of those things are symptoms, and some of them are just being a person. Did you hit your head?
No. Oh, yes, technically I did smash my head.
You mentioned on the phone that you had some dizziness.
Yes, a little dizziness, and I think I'm developing a hearing loss in my right ear, or my left ear. No, I'm sorry, it's my right or my left ear. Now I can't remember.
Okay, let's take a look.
Well, if it's a concussion, it's extremely mild, so I wouldn't worry about it. Anything else bothering you?
Nope.
Okay.
Well, I mean, yeah, I've got a weird rash in my knee pit area. And my tongue inside doesn't taste anything anymore. Sometimes when I walk, my ankles make like a weird rattle, snake sound.
Well, I'm sorry to say you have had a significant drop in the high decibel range of your right ear.
What else? Things that are far away from my eyes are fuzzy. I once ate a Twix with the wrapper on it, and I've never seen the wrapper come out. Also, I've swallowed a piece of gum that I've chewed for the past 25 years. I don't know. I broke my thumb and just fix me.
Well, I can help you with the thumb.
No, I've been perfectly healthy. You know me, I always imagine that I have things.
When did you first notice this?
Well, about a month ago. What do I have?
You've had some dizzy spells. What about ringing and buzzing? You noticing you have?
Yes, now that you mention it, I have buzzing and also ringing.
I'll have to give you referrals for specialists for the other 1,000 things.
Wow, thanks for nothing, Dr. Harris.
You're welcome.
I have a brain tumor. I don't know what I'm gonna do.
You have a brain tumor. He didn't say you had a brain tumor.
No, naturally they're not gonna tell you because, well, you know, sometimes the weaker ones will panic if
But
you tell
not
them.
you.
Is there a buzzing? Is there a buzzing?
Okay, come on, we got a show to do.
I can't keep my mind on the show.
But there's nothing wrong.
And the internet's making this worse, giving people the idea to run their symptoms and find all different types of diseases.
Keep calm. You're gonna be okay. Don't panic. I'm dying. I'm dying. I know it. There's a spot on my lung. Now, take it easy, will you? It's not on your lungs. It's on your ear. It's the same thing, isn't it? Jeez, I can't sleep.
Well, in Chinese medicine, they have a very good cure. They give cockroaches or live beetles. Yes, they actually give these things to people because most of the time a hypochondriac doesn't want to eat those type of things. Here's the hypochondriac convention. Same as last year, everybody called it sick. Well, this actually can be the fact that there really is something that they haven't diagnosed, or perhaps they need to really look into it. So I think that you need to understand. Having cockroaches can help hypochondriasis. And if that cures you, then it's probably because you didn't really have the sickness anyways. But just like this fellow said, I told you I was sick. Hypochondriasis, gravestone.
Okay, that's a good one. Let's let it end with that. That's pretty good. Oh my gosh. Oh man. Okay, they are something else. No doubt about it. Okay, this one is actually pretty fun. This is even fun too, but really weird. How many of you have been exposed to a patient who actually made up being sick? I mean, made it up. Tell us about it, Paul.
Friend of a friend became convinced that she had cancer because of Dr. Google, and went to tons and tons of doctors. No one said she had anything, but she was still convinced, and so she preemptively shaved her head because she didn't want to lose it progressively throughout chemotherapy, and so she just made it all up, and she does not have cancer, and she is now bald.
Does she still have cancer?
No.
Does she still believe,
she
does she still believe
still
that?
believes that something's wrong with her.
Oh my gosh.
But like nothing, she does not have cancer.
Oh wow.
Yeah.
Oh man. I've seen some odd things at OU Medical Center, and most of them I have put on these slides and want to know where people fake things, take things. And it's just amazing what they will do to look sick. So, factitious disorder imposed on self, because there's also factitious disorder imposed on others, usually mothers doing something to their children to draw attention. Okay, so there's a falsification of physical or psychological signs or symptoms, or an induction of injury. So they either fake something, or they actually do something to themselves to kind of mimic something, some evidence of a disease. And they're all done with the intention of deception. They do it to trick you on purpose. That's part of the diagnosis. They present himself or herself to others as ill, impaired, or injured. The deceptive behavior is evident even in the absence of obvious external rewards. So you could, you hear about the secondary gain. They act this way because people treat them better. Okay, well in this case, the diagnosis is they would still act like they had the illness even if there wasn't anything yet to be gained from it. It's not explained by anything else, and it can either be a single episode or it can be recurrent episodes. The ones I've known, we actually tracked them down because it was recurrent. You go back to previous admissions and other places they've been, and they will tell you what they've done, and they're kind of a pariah in the healthcare system. Now, factitious disorder imposed on another is falsification of symptoms or inducing injury in another, also with the intent to deceive. The individual comes with somebody else, okay, comes with the individual, which is defined as the victim, and it can be a child, an older adult, somebody that really is probably not able to care for herself, or a pet. You do it to my dog and you will have a real injury, okay, it won't be fake, or others, and they bring him in as ill, impaired, or injured. The deceptive behavior is evident even in absence of external rewards, not explained by anything else. The perpetrator, not the victim, receives the diagnosis. So the person who's doing it to somebody else is the one who's got factitious disorder. Do you know what they call it when it's the victim? The victim has a name too. It's by proxy. So it'd be factitious disorder by proxy. So that means you didn't do it, but you're the proximate victim. You're in the vicinity. Okay. Now everybody's heard of Munchausen syndrome. Munchausen syndrome is not really identified in DSM-5. It's all up under this factitious disorder, but it's a special variant of factitious disorder. So Munchausen syndrome is factitious disorder with mostly physical symptoms. Okay, it used to be its own category. It's just not anymore. They've grouped them all together and put factitious out there. You either do it to yourself or do it to somebody else. If you focus heavily on physical symptoms, then you could also call it Munchausen syndrome. Be suspicious of this more extreme form of disorder if you see the following: dramatic but inconsistent medical history. They can't tell you everything about how they got to be where they were, they just are. Okay? Unclear symptoms that are not controllable and that become more severe or change once treatment has begun. They really don't want to get better, so they will subvert treatment and get sick in another way or not do something so they'll be sicker, because they're intent on being that way. They have predictable relapses following improvement in the condition, and they have extensive knowledge of hospitals or medical terminology as well as textbook descriptions of illnesses, particularly with the internet. A lot of times they're healthcare providers who have the mental disorder, and they know so much stuff about the system and how to pull stuff out of the system that they can really get you going. They know all the words, they know all the system, they know where the records are, they know where the lab is, they know how the lab is done, they know how to intervene and get stuff and mess it up. I've seen it with nurses who are really good about systems, so it's not that uncommon in healthcare people. Be suspicious if you see lots of surgical scars, if you see the appearance of new or additional symptoms following a negative test result. Now I got to go this direction because they got negative on that and they're not going to pay attention to me, so now I've got to be messed up over here. They'll do that. Presence of symptoms only when the patient is with others or being observed. If you run cameras on people, they might be limping and, I don't know what it is, I can't do that, I can't do that, and then all of a sudden you have the camera that just work around like normal. Oops. It's kind of like an oops. Willingness or eagerness to have medical tests, operations, or procedures. They want you to cut on them, poke on them, and prod on them. They have a history of seeking treatment in numerous hospitals, clinics, doctors' offices, possibly even in different cities. When you have people who bring you a laundry list of all the people they've seen, if they're willing to share that with you, you have to be suspicious. That's not normal. Most people want to have a relationship with a provider, and if that works out, that's kind of it. When it's like 10 or 15 in a 3-year span, that's kind of probably not normal. Okay, reluctance by the patient to allow providers to meet with or talk to family, friends, or prior providers. I've called prior providers on people, and as soon as you say their name, they go, I want to, can I ask you a question about Miss Smith? Thank you. Because by the time you get to that, you're already suspicious of stuff going on. Problems, these people have problems with identity and self-esteem. How do they fake it? There's different ways that they can fake stuff. Exaggerate. You know, my headache is just killing me. It's just, I can't stand it. It's just throbbing, pounding. What test can you do to prove that? Nothing. Fabrication, just outright lying. How about adding blood to the urine? How about falsifying a medical record? How about inflicting wounds on self or others? Okay, just cut themselves to be sick. Simulation, faking a blackout or a seizure. How will you know? I mean, seizures are pretty easy to fake, honestly. You can get out there and start flailing. Induction, ingesting a substance, for example, insulin or warfarin. Injecting fecal material to produce an abscess or induce sepsis. I've actually seen that. I saw that at OU Medical Center, and that is disgusting. I mean, think about how disgusting that is. I had a patient at Oklahoma City VA who actually wanted narcotics, and he had been limited because he was clearly an addict and a seeker. And so he pulled out a revolver, shot himself to the fleshy part of the calf after we had told him one day that it cannot be done anymore, and he'd been limited on the Substance Abuse Committee, and I was the chair of the Substance Abuse Committee at the time. It was a fabulous job, but you don't want it for long stretches. And then the guy went out of the building that day, came back late that evening, shot himself in the leg, came up to the counter and said, "Now you have to give me a pain medicine." He's like, "I'm going to force you. Here I am. I'm a veteran. I deserve treatment. I've shot myself." And we said, "I am so sorry you've done this to yourself. We will clean out your wound. We will give you antibiotic. We'll do all the things we do. If you would like to receive pain medication, you will have to go to another facility. Hit the road, Jack." And he left. But, I mean, that's just like hijacking you for treatment. Crazy. I've seen people do the insulin thing. This is an easy one because what evidence do you have? With these synthetic human-like insulins, unless you're going to do elaborate assays, you already have insulin in your body. And then you're thinking, we had a patient in Austin, Texas, and for the life of I was on the internal medicine team, everybody thought the person had an insulinoma, which is you'll learn it's a phenomenon. There are tumors that are insulin secreting, and they just secrete insulin at unexpected times, and you can just have a blood sugar crash and get hypoglycemic. Well, this person was factitiously injecting insulin, and at final point, we raked their hospital room because they were trying to work them up for insulinoma, and it's really hard to find it. And so they were raking his room out. One older intern said, they're doing something. So they raked everything out and finally found a bottle of insulin, and they were injecting in the hospital to be sick. You know, it's the one that he killed themselves. They had to have some sense of how much would get you hypoglycemic but not kill you. But I will tell you, that was still risky because they just don't quite know how that's going to play out. Here's some of the common medical problems used factitiously. Hypoglycemia for the reasons I said. GI bleeding, you know, you can put blood in vomit, blood in stool, guaiac yourself and drop. They give you the guaiac cards to go home, do 3 and mail them back. 1, 2, 3, blah, blah, blah. Got a bleeding tumor or something. Yeah, bleed tumor, something else going on down there. Anemia via self-phlebotomy, bleed yourself. get anemic, pseudo-seizures, brain tumors, mental disorders, fainting, hallucinations, and delusions. So there you go, Ron. There's people who actually just, they fake it, and people do fake stuff a lot. So how would you know? Have to keep looking, thinking. Prevalence unknown. Exact cause of factitious disorder is not known, but researchers think it's a combo of a biological and psychological factors, none of which they really are quite certain of for these patients. Some theories suggest that there is a history of abuse or neglect as a child, or a history of frequent illnesses in themselves or families that required hospitalization. And so if there's a history of abuse or neglect, it's a way to get the attention for yourself that you did not get when you were younger, and it seems to be a more positive attention. We're trying to take care of you because their family wouldn't take care of them. And then it's the same thing for frequent illnesses. It seems more pleasant to be sick. People treat you better and different than you get treated when you're not. There's often histories of abuse, trauma, family dysfunction, social isolation, early chronic medical illness, and professional experience in healthcare. Some think it might be a search for nurturance. Many are caregivers and may be searching for a role reversal. That's why I told you I've seen nurses. They take care of, take care of, take care of, take care of. I want somebody to take care of me, and I'll just get sick because that's what I know in the caregiving world. Need for power and superiority. You're in control when you're sick, and you're controlling the sickness. You're manipulating all the people around you on the healthcare team. Or create a sense of identity. I'm ordinarily a nobody, but if I have cancer, I'm special. When confronted with the possibility that they're faking it, they are hostile, angry, they may even threaten to sue you. They'll come at you, and they'll leave you, and they'll hate you. It'll be okay. Differential diagnosis, a lot of things. These are the hard ones. Ron, I promise I won't mess you up this way, but somatic symptom disorder, where it's real suffering, and they really believe that that's happening, to I faked it. So you got to find the fake part. Conversion disorder. I'm not really covering this in our topics, but a conversion disorder, old definition is hysteria, but DSM-5 is conversion disorder. Patient has symptoms of altered voluntary motor or sensory function that is incompatible with the neurologic and medical conditions. It's like people who get, they just freeze, they can't talk to you, or they just faint and they just can't do it. It's just a hysterical reaction against whatever, okay, to draw attention in. Borderline personality disorder, because it's a way to manipulate and get power and control over people, so you have to watch out for that. A medical condition or mental disorder not associated with intentional symptom falsification. Maybe they do have cancer, maybe they do have a brain tumor, maybe they got a symptom and it's real, and not fake. And then there's an old diagnosis called malingering. Everybody's heard about malingerers, the malingerer, coming to the ER wanting to know till they get off from work, those type folks. There is an intention to deceive for personal gain, okay? To obtain drugs. Some do it. Okay, my man who shot himself through the foot, or through the calf, was trying to manipulate for personal gain to get the medicines. And then you also have to get out of work, school, and whatever. The treatment, it's a lot of behavioral stuff. You want to change the behavior to reduce the misuse of medical resources, in the case where it's imposed on somebody else, your goal is to save that person from abuse. I mean, a child that's being injected fecal matter, there was a child at OU Medical Center that had sepsis, and it was because the mother was actually taking the diaper, drawing up leftover fecal matter and injecting it. She was a drug addict herself. And, I mean, does that not make you sick? It's criminal, psychiatric, everything else you can possibly think of. Once the goal is met, then you resolve any underlying psychological issues that might be leading to the behavior. Primary therapy is psychotherapy, cognitive behavioral therapy, family therapy may help in teaching family members not to reward or reinforce the behavior of the person with the disorder. So not only do you work with the person, but you work with the people around the person because often they have dysfunctional systems and they get, reinforced when they go back into their natural habitat in a way that doesn't lead to a cure or an improved outcome. There are no medications to treat factitious disorder. Now you can use it for other aspects if there's true depression or anxiety that's superimposed with it. You can do that. Okay, here's some scenarios. Look at these. Sarah complained of chronic diarrhea. Boyfriend confirmed her symptoms. Test for a common ingredient in laxatives was positive. Looks like there's a phenolphthalein test you can do, and phenolphthalein is included in a lot of laxatives. Positive. So she was inducing her symptoms. During the course of the therapy, Sarah subsequently acknowledged that she enjoyed the attention she received while in the sick role. She did not have underlying eating disorder. She just liked being sick. Take a look at this one. This one's yucko. Okay, is that not disgusting? Disgusting to the point of multiple surgeries. Yeah. Y'all seen it? Okay. Look at this one. This is in another. Okay, so she was faking bloody diarrhea. And you'll see that a lot of times, that's actually kind of common when people will get out of the hospital before you finish all your diagnostic workup. They may feel like they're kind of losing their perception, so they will disappear, and you have to kind of wonder where are they going. A lot of times you'll have other agencies, social work, other administrative officers in the hospital track down to figure out where they're going, to figure out what they're doing, because you're curious. And look at this one. This one is just malingering. So this stuff happens. Okay. Okay, what do you think this is?
Well, tonight we are continuing our coverage of the Angola woman accused of faking cancer to get money from a fundraiser. Last night, in a News Channel 15 exclusive, April Landis said she has factitious disorder and that it made her think she had cancer. Today, News Channel 15's Alyssa Ivinson talked with one of Landis's relatives, and what did she have to say?
Well, she says April Landis has a history of making up illnesses, and she thinks April is lying again now. But Landis says she's never tried to scam anyone.
So you absolutely did not lie to get money from a bank?
No, ma'am. Nope. Like I said, I'm not about money.
In an exclusive News Channel 15 interview, April Landis says she has a mental condition called factitious disorder. Landis faces 4 felony fraud charges. Police say she faked having cancer to get money from a fundraiser. But Landis says the factitious disorder made her believe she really was sick.
A factitious disorder is the development of psychological or physical symptoms. They're starving for attention, they're starving for sympathy. And there is really no better way than having a medical problem.
Dr. Stephen Ross is a clinical and forensic psychologist. He says people with factitious disorder will often go to doctors over and over with different symptoms, even create physical symptoms. But the key is it's just for attention.
A true factitious disorder, they believe that they have a real problem. Now, the point to be made is this. If there is a secondary benefit, a gain of some sort, money, getting off of responsibility for a criminal offense, that puts it into a different category, that puts it into a malingering.
Landis says she's always had migraines, fainting spells, and other issues growing up.
Stomach aches, whatever, and a lot of that actually, from what they're thinking, was, all brain.
Today, News Channel 15 also talked to one of Landis's relatives. She didn't want us to use her name, but says Landis has a history of saying she's sick, even saying her kids are seriously ill. She says after a family member had a heart attack, Landis said she had heart problems the next week. Landis said she had cancer a week after her grandmother died from the disease. Now, this family member isn't buying the factitious disorder.
I don't understand it, how everything can be so real to me, but not to everybody else.
Landis showed us paperwork from the Northeastern Center in Auburn diagnosing her with the condition, and she says she still struggles.
Part of you still thinks and believes that you have brain cancer.
Yes.
Right now.
Yes.
At this very moment.
Mm-hmm.
Landis is going to therapy once a week. She'll be in court for the felony charges on May 14th. Live in News Control, Alyssa Ivinson, News Channel.
Okay, thumbs up or thumbs down? I think thumbs down. I'm giving her a no. I think she's faking it. Let's take a break. I will do the body dysmorphic when we come back right before we do the cases. And so just go get your food, go have your fun. We'll be back.